Okay, we're going to have a look at standing posture, and I'm going to speak briefly about how to assess standing posture and then also some of the major postural corrections that you might see. So first of all, when you look at someone as far as standing posture goes, it's a good idea to get them in no shoes and just fairly perpendicular to a wall. I think that just helps with your understanding of where they are in space. When you're looking at them, first of all, you want to have a look at their overall body position in a sagittal plane. So the two bony landmarks we usually use, first of all, the centre of the thorax, so you might say kind of the centre of the shoulder, just kind of allowing for any variations in their glenohumeral position there, but about the centre of the thorax, so the glenoid fossa, and then about the centre of the hip joint itself, or the greater trochanter. So first of all, you're looking for those two bones to be in the same plane vertically. And what you'll see at the moment is we have Kaylin just in a slight sway where her hips are sitting just a little bit in front of her shoulders. So if you wanted to instruct her of how to correct that, you might just get her to put one hand on her stomach and just push her stomach straight back underneath her, and almost like she's about to bow until those two bony landmarks line up. Beautiful, thanks for that, Kaylin. Lovely. Now the second thing you want to look at is where the pelvis naturally sits. So for the pelvis, you're looking at the ASIS versus the PSIS. And with those two bony landmarks, you can wrap your finger around, or your hand around the pelvis itself, or you can put one finger and then the other finger and potentially use a mirror in the sagittal plane across from you to see where the relationship of those 2 points are in relation to each other. And so what you're looking for is for the ASIS and PSIS to be in approximately the same plane, or you might have up to a 25-degree tilt forward of the PSIS being higher than the ASIS. So all of that is within normal range. If you're kind of unsure as to whether the person is in an anterior pelvic tilt, you might then just have a little look at the lumbar spine, and you're hoping that the lumbar lordosis is only confined to the lumbar spine and not extending right up to the thoracic spine as well. So that's the second thing we're looking at is the pelvis itself, and I would say that Kaylin is in about a neutral pelvis. The third thing we want to quickly correct is the ribcage position, and so when you are looking at the lumbar spine, you may continue up to see what the lower thoracic spine is doing. And you'll see there that Kaylin does have a little bit of extension in her lower thoracic spine, and you'll see anteriorly that does correspond to her being in a little rib flare. And so you can reference your 5 key elements workshop to understand ways of correcting the rib flare, but we're going to just instruct Kaylin there to just drop her ribcage just a tiny little bit, again like she's about to bow, to correct that posture there. Beautiful. Now the last thing you do want to look at is just where the person's body weight falls through their feet, and so what you're hoping for is that the weight passes into the anterior ankle. Now some of the other postural or the common postural faults that you may see in your clients, number one is an anterior tilt. So an anterior tilt is generally pretty obvious because they'll have that big lumbar lordosis, but most importantly have a look for the ASIS versus PSIS, and you'll see that there's a big difference in that relationship. So with the anterior tilt correction, you're just trying to get them to use their lower abdominals to lift their pelvis back up and to bring themselves into that same plane. Be careful with that correction that you don't get them to use their glutes and their hamstrings to pull them down, because that probably won't allow them then to have those muscles available when they want to run and walk, when they choose to move. So usually using the lower abdominals is the most sustainable way to correct that posture. Another postural fault you may see is a posterior pelvic tilt. So with the posterior pelvic tilt, generally you'll see a very flat lumbar spine. These people tend to be a little bit more predisposed to lumbar disc issues and things like that, because of that lack of extension and lack of multifidus. So what you're looking for that person is to try and get them into a neutral spine in the vertical axis first, and then just get them to kick their tailbone a little bit back out behind them. Now very important with that movement comes from the lower lumbar spine, and the muscles that will be doing that are the multifidus. What you're trying to be careful of is that they don't do that movement with their erector spinae, which will send them into a general anterior tilt and potentially even a rib flare. So that movement needs to be very isolated, and they may even describe, or they should describe, they feel the sensation around this area here. Now the third postural correction we're going to talk about is a sway, which is a very common postural fault. And generally with a sway, that's the one where the hips sit quite significantly forward of the shoulders. Now often with the sway, what you'll see is that you'll see their hands are falling back behind them. You'll often also see that they have developed a secondary thoracic kyphosis and maybe even a chin protrusion as a result. Now with the sway, all you're looking to do is to bring the pelvis back into the same plane as the shoulders in that horizontal plane. One thing to be careful of though when looking at this person is it's very easy to jump to the conclusion that they're in an anterior pelvic tilt because they have that increased lumbolidosis. But if you check the pelvis itself, you may actually find that that pelvic tilt isn't there. So always correct this way first by getting them to put their hand on their tummy and then push their tummy back underneath them until they've got that nice vertical line of the thorax stacked on top of the pelvis. And then once they've corrected there, you can then just have a quick reassessment of their pelvis. And some people may drop into a pelvic neutral, some people may come out of a pelvic neutral, and you may have to have a secondary correction for those people. But I hope those few points have given you a little bit of an idea about what to look for in a standing posture sense, and good luck with your corrections.